It gives me quite a bit of pleasure to introduce Dr. Gleason. He is currently the Executive Vice President and Chief Clinical Officer for Prisma Health, where he has broad responsibilities for the clinical and academic mission of the 18-hospital clinically integrated health system with one of the largest medical groups in the country. Prior to joining Prisma, John led 2 major post-merger clinical integrations by designing learning systems that have achieved consistent results in quality and safety improvement. His work has extended beyond healthcare into retail environments. He served as principal for the co-development of EverSafe OS with the global business service company Aramark. Recognition for his work includes the National Quality Forum Next Generation Innovator Award and the ECRI National Patient Safety Award. He serves as faculty for the Institute for Healthcare Improvement's Chief Quality Officer School and teaches healthcare improvement at Harvard and as a clinical professor at Clemson Universities. In the past year, his work has been widely cited, including the World Economic Forum, Modern Healthcare, and the Wall Street Journal. He serves on multiple boards, editorial boards, and committees, including the Special Olympics in Pennsylvania. As many of you may recall, Dr. Gleason completed undergraduate medical school at the University of Georgia. He trained in obstetrics and gynecology at the University of Pennsylvania and did his female pelvic medicine and reconstructive surgery at UAB, 2009 to 2012. I am very pleased that John could join us today, and he's going to talk to us about COVID-19, the safety moment of modern healthcare. Thanks again for joining, John, and we look forward to hearing you speak today.
Thank you, Dr. Richter. Wonderful to be with you all. I'm only sorry that I'm not there in person. I was just saying, I think before many of you got on the line, how fondly we think back on our time at UAB and Birmingham in general, and the friends that we had there and still have there. And it was wonderful to be with you all at Alabama ACOG just a couple of months ago, celebrating Dr. Varner and his retirement and all that he has done. And just want to congratulate all of you on being at UAB. It is a very unique place, and I've had the privilege of being at several great places, and UAB stands out among them in a number of ways. You know, and a part of it is just a sort of relentless commitment to excellence that's deeply patient-centered, that Dr. Richter and everyone there taught me, and has had a major impact on my life and even the direction of my career. Much of our research there at UAB and the department was really deeply focused on the profound needs of our patients and was inspired by the patients, and not only curiosity about disease process, but really focused on the needs of the patients. So, you know, I just have great affection for UAB, and it was an easy one to say yes to. And so, does someone have my slides, or would you all like me to share my screen?
What do we got, Christy? Do we have a slides? Maybe just go ahead and share your screen, John.
All right. It's a little bit dangerous, but we'll see how it goes.
I totally understand that.
Yeah, okay.
It's up.
All right, let's see here.
Sticking
How's that?
That's awesome.
Okay, great. So we're going to talk about the impact of COVID on patient safety and review maybe in a little more detail some of the things that you're hearing about what the impact of the pandemic was. Of course, the pandemic impacted everything from gas prices to obviously our whole social construct in our country and really around the world. And patient safety was dramatically impacted during the pandemic. So I just want to level set a little bit on what happened during the pandemic relative to patient safety, and then how that feeds into the need for a total systems approach to patient safety. And we'll talk about the components of a safety system, and I'll do a little bit of storytelling along the way. So I think this group is aware of the global significant warranted concerns around patient safety. Of course, original paper on this that called a lot of attention to patient safety was To Err Is Human, published in 1999, which led to just dramatic changes at the Joint Commission and CMS and even electronic health records, which at that time were not very prevalent in health systems. There were less than 10% of health systems at that point had an EHR across their system. And one of the rationales behind pushing EHRs out was patient safety. So just an enormous amount of work and impact from that important paper, which demonstrated totally unacceptable high rates of preventable harm, and not just minor harm, but serious harm. So healthcare got to work, and unfortunately in 2015, when a similar analysis was performed by the National Patient Safety Foundation, the results were very similar to 1999, and there really had not been a major impact on overall safety and outcomes in healthcare, despite all of the efforts, all of the investments over that period of time. In a book that I'd recommend to any of you that are interested in safety in particular is Still Not Safe by Kathleen Sutcliffe. Kathy Sutcliffe is a wonderful researcher. She is a nurse and a scientist by background at Hopkins, and she is credited with the principles of high reliability, which she's published, and had a major role in the patient safety movement beginning after To Err Is Human. And she was reflecting on why the patient safety movement had such little impact on patient safety. And that book came out late in 2019 on the eve of the global pandemic, COVID-19, which really clearly illustrated many of her points about the limitations on our approach to patient safety, which to that point, just to summarize what her points were, is that we really took a social systems approach to safety after To Err Is Human. There's a tremendous amount of focus on improving people, culture of safety, having a team-based approach, which is obviously incredibly important, but also demonstrably insufficient. And so what she was pointing to is that healthcare really did not look to system safety, science, and industrial engineering for solutions to safety issues. We really looked within ourselves, and we didn't look outside of industry to find solutions. And I'm going to talk a little bit in a minute about what I think some of the implications on this are for, what I see as one of the next big movements that's beginning to occur in healthcare, where we need transformation, just like we need transformation in safety, and that's around health disparities and health equity. I think there's a real danger that we take another amateur approach to health equity, like we did with the patient safety movement. So, as an industry, if you want to call us an industry, we really need to practice deference to expertise with regard to safety and with regard to other complex issues that may not fall within our skill set, things like health disparities in the social sciences. So when prior to the COVID-19 pandemic, there were many that were calling attention to patient safety issues, even prior to COVID-19. This is Dr. Makary, now famous for all of his work during the pandemic, but he published a BMJ paper in 2015 that got a lot of press, essentially illustrating the medical error was the third leading cause of death in the United States. And, as Dr. Richter taught me very well, I'm looking at the data, and that may or may not be accurate, but even if it's a little bit off, it's very concerning. Anyone disagree? So there is unacceptable high rates of preventable harm. And so just with that as backstory, I'm going to shift a little bit and do a little bit of storytelling around the pandemic. And I'm going to walk you through some of my experiences and some of the work that we did. And then I'm going to use that as a framework to talk about where I think healthcare is going relative to safety. So during the pandemic back in 2020, I was serving as chief clinical officer for the largest health system in Philadelphia, Jefferson Health, 18 hospitals across Pennsylvania and Jersey. And obviously following the pandemic, and the picture on the right is a picture that I took with my phone. I was standing at the Philadelphia Flower Show, which doesn't sound like a big thing, but if you're from Philadelphia, you know that it is. It is a massive deal. Hordes and hordes of people coming to see the flowers in a major venue there in Philadelphia. And I was standing at the flower show when I got the call from our lead for infection control to tell me that we had our first test positive case. This is the, I think the only Steven Spielberg moment that I've ever had in my life, where I contemplated what my role was at that moment. Am I supposed to pull the fire alarm? All these people need to get out of the building. COVID is in Philadelphia. And so we stood up incident command, and what you're seeing there on the left is the first incident command meeting of our health system there in Philadelphia, being led by Rich Webster. And what you'll notice in that incident command for the pandemic is that no one was in masks, right? Because at that point we weren't sure that they were necessary. So this is just a little walk down memory lane, just to kind of level set with you all, kind of a little bit about what we've been through, because it's been one crisis after the other, and it's easy to forget, even though it was very recent. Following that, this is Dr. Farley, the health commissioner there in Philadelphia, announcing that first case. And of course, we all know what happens next. So one of the things that I think is a real learning from the pandemic is it was the outsized impact of health crises on vulnerable populations. And so that was a real interest of ours during the pandemic in Philadelphia. And I'm going to share a little bit about some of what we learned, because I think it impacts where we need to go with quality and safety on a national level. So in Philadelphia, we were also providing safety service to 302 long-term care facilities, nursing homes, and other sorts of long-term care facilities during the pandemic. So we provided them PPE and testing. We had a SWAT team that would go out and provide stabilization services and transport when this is pre-pandemic, when COVID would get into one of those facilities. And one of the most significant and tragic things that I saw during the pandemic was at a long-term care facility that catered to people with intellectual disabilities. And long story short, the National Guard came and got involved, and we ultimately evacuated that. And it just became very clear that people with intellectual disabilities who don't have typical control over their behaviors are less able to use behaviorally based risk mitigation strategies. Seems very obvious, right? They are less likely to be able to wear a mask, to keep their distance, and to wash their hands, right? People that don't have typical intellectual abilities. And so, of course, because of my research background with Dr. Richter and all the papers, we did a large retrospective cohort study using the Vizient CDB database, 64 million US patients, and the adjusted odds ratio for dying from COVID-19 during the first year of the pandemic for those with intellectual disability was 5.9, which is an unbelievable adjusted odds ratio. And of course, I looked at that and said, that's not right. Do it again. And then it came back and I said, again, that can't be right. Do it again. And then we started looking at the data, the descriptive data, and the impact was real. The study was repeated. This analysis was repeated in the BMJ. And just in the last couple of weeks, a large study showed that COVID-19 was actually the #1 cause of death for people with intellectual disability in the first 18 months of the pandemic. So we published this paper in March of 2021, March 5th. This is right in the middle of the vaccine deployment. At that time, if you'll remember with me, there was scarcity of the vaccine. And so we were doing the very difficult work of trying to determine which populations were at the highest need and would be prioritized first for the vaccine. Those with intellectual disability were not on that list. That was news, right? This was news that this was a major risk factor for severe COVID. And so you can notice there, March 5th, within 5 days, civil rights lawsuits have been filed in multiple states. I guess this is this West Virginia, but Maryland, Connecticut, Kentucky, multiple states, individuals with intellectual disability or their family members filing suit against their state for not prioritizing their their family member with intellectual disability for the vaccine, despite the clear evidence of the risk. One day later, we were able to get Philadelphia to move against the CDC guidelines and extend vaccine prioritization to that population. And this is a couple of days later. You can see Kentucky, after being pressed and being sued, changed their vaccine prioritization. Japan, India, other countries around the world, literally within days, changed their prioritization for people with intellectual disability, and the studies keep coming. So what did not happen is the CDC did not extend prioritization of the vaccine to those with intellectual disability. Paper came out on March 5th, 2021, and we, myself and collaborators, we partnered with Special Olympics International and many others to advocate for this community, and that effort was unsuccessful. And in December and January through 21 and 22, you'll recall that we had new treatments for COVID-19 that came out, which, for reasons that I can't talk about because it makes me so frustrated, we also had scarcity with those medications when they came out. And so we were back in the place of trying to prioritize a limited resource, life-saving resource, for those at highest risk. And again, those with intellectual disability were not included in that. So this is an op-ed that we published, and very quietly, about 4 or 5 weeks later, the CDC did include intellectual disability as a risk factor for severe COVID-19, opening the door to prioritization, not only for treatment, but for all kinds of services during the pandemic. So, that whole issue has generated quite a bit of attention. And this is Tom Golisano, who gave a $30 million gift to Special Olympics International, their largest gift ever, to try to address health inequity related to intellectual disability around the world. And I was in New York 2 weeks ago with the Deputy General of the World Health Organization, US Surgeon General, and a few others, talking about how we should address this significant disparity, and have another paper actually coming out in HAM Catalyst in a couple of weeks that'll describe global knowledge and understanding from physicians about the specific needs of those with intellectual disability. So what I'm saying is it relates to quality and safety is, and the pandemic, lessons learned from the pandemic is, I think we've had a very kind of myopic view of safety and quality in the country. It really hasn't been population based. It's been episodic. We've been focused on episodes of care and not necessarily focused on safety from a population perspective. Does that make sense? Holly, anytime anyone wants to interrupt me, I'm like happy to be interrupted, and we can make a small enough team. So if anybody wants to jump in.
Good deal. Okay, thank you.
Sure. So, I think that's one of the key lessons from the pandemic is that, safety, especially when you get to population health level, isn't only about CLABSIs and CAUTIs and falls with injury. Those things are incredibly important, but this is a very different way of thinking about access to healthcare services, right? Are we actually enabling people to have the treatments that they need? And so, I think one of the needs in coming out of the pandemic, and this is just one example of that, there are others. There's tremendous evidence around health disparities related to race and ethnicity around the country, and radical disparities in health outcomes and access to health services along those lines as well. But I think that's one of the core things that we've learned from the pandemic, and you're beginning to see CMS and other important stakeholders requiring, and actually beginning in January of this year, as a condition of participation in CMS, health systems will have to look at specific safety and quality outcomes within specific populations of people. Of course, they've not included intellectual disability at this point. I would say yet. I think they will, but they haven't done that yet. So I think that that's one of the important sort of new frontiers around safety and quality. So maybe we'll pause there. Any questions about that from anybody, or does anyone have any thoughts on that? Obviously, in OB, we have the privilege of serving patients, some of whom have profound social determinants of health. And at OB, one of the wonderful things about OB is we do team-based care, right? And we take a holistic approach to our patients. I think that's one of the characteristics of our specialty overall. What are your thoughts on this? Any questions or thoughts, comments?
Not really, John. I think it's a lot of material that we're trying to, soak up now, and we'll see what happens at the end if we have some further insights.
Okay, so that's a high level in terms of what I think is going to be where healthcare is going to go relative to safety and quality following the pandemic, is taking a more population view of safety, and CMS is getting engaged in that process as we speak. The other thing in terms of core principles around the management of safety is that really demonstrated the necessity to adhere to the principles of high reliability. I know that this group is familiar with these. Here's Kathy Sutcliffe again in her original paper. She was at the University of Michigan before she went to Hopkins. But those principles of high reliability are preoccupation with failure, which means that we come to work every day not assuming that everything is going to go well, but with an understanding that things may not go well, and we're vigilant and alert to where concerns may arise. A reluctance to simplify. So reluctance to simplify is critically important in the management of safety. Healthcare is a very complex system of care. It really is socio-technical work where it's a sort of complex interaction of humans and machines. And where we take simplistic approaches to safety, we can oftentimes create more harm. And sort of the most understood example of that is around alarm fatigue, which probably is a familiar concept to you all. Alarm fatigue being that if we have an alarm when the blood pressure is down and when the blood pressure is up, when the heart rate is down, when the heart rate is up, when the O2 sat is down, when the respiratory rate is up, when I need a snack, when I need to go to the bathroom, when on and on and on, you can create an environment where there's so many alarms that it exceeds your capabilities to interpret the alarms. And I first understood this issue when working with an engineer on this issue in ICUs. And we walked up to a nursing station and we're just trying to take an inventory of all the alarms. So I was trying to solve problems. And we asked her when an alarm went off, hey, what's that alarm? She said, what alarm? And we said, that alarm. She said, what alarm? I said, that alarm. She said, what? So we walked over to the machine. It was an IV pump. And she said, oh, I hear it. And we said, well, what's that alarm for? She said, I don't know. Okay, so what are we doing here, right? We've created a system that exceeds our human capabilities and doesn't account for limitations. And so that is an example of where we've simplified a really complex problem. So reluctance to simplify is incredibly important. Sensitivity to operations means that we know what's going on a day-to-day basis, on a now basis. And I do think that during the pandemic, health systems and health companies did make progress in this area because we were having to manage throughput in a different way. We're having to manage safety in a different way. We're having to look almost hourly at things like mask supplies and staffing ratios, the number of COVID patients and outbreaks. So there was a lot more rigor during the pandemic and how health systems had to operate just to be able to survive. So there was a lot more use of data on day-to-day operations within health systems during the pandemic. Commitment to resilience, which means that we solve our problems and we continue to work the problems, and then deference to expertise. This is one that I'll just make a couple of comments on. So during the pandemic, and one of the areas where I saw health systems get in the ditch is not practicing deference to expertise with regard to infection prevention and infection control. So you saw some pretty significant mistakes that were made in health systems where they did not allow their epidemiologists and their infection preventionists and their infection control departments really manage things like PPE. And so there is there is more, I think, awareness at this point of the need to practice deference expertise when it comes to things like hospital policies. So deference expertise, I think that's one of the core principles of high reliability that COVID-19 demonstrated a very significant need to adhere to. But it really is kind of a sad story about what happened to patient safety during the pandemic. So I'm just sharing with you some of the studies that have been published. This is from your own Dr. Lee, from Penn's Dr. Lee Fleischer, who's a CMO for CMS, and he published a large study about the significant increases in patient safety events during the pandemic. It hit broader in the press, Becker's Hospital Review. There was another New England Journal paper talking about health disparities related to race and ethnicity. And so there were increases in safety events during the pandemic, but there was a reduction in safety reporting during the pandemic. So you look at that study there on the left from Denning in 2020, which just shows that even though there were more safety events during the pandemic, there was less reporting of events during the pandemic. So this is a sad story for healthcare, and that led to, in May of 22, a national urgent call to action from the Institute for Healthcare Improvement and 27 stakeholder organizations like National Quality Forum and others, calling for health systems to take a total systems approach to the management of safety. That really we weren't resilient to the stressors of the pandemic, and that our approach to safety and quality really does need to be revisited, just from an operations perspective, but also from a scope perspective around things that I've talked about relative to health disparities. So this is a big deal. It is going to become a bigger deal. I was on a call yesterday with leadership from CMS about this. The president is going to speak about this issue soon, and CMS is going to take pretty significant action because of the significant decline in patient safety that we've observed during the pandemic, despite the awesome people that we have in healthcare showing up every day to do their very best. So this is something that came out from Dr. Walensky just literally days ago, which demonstrates also an increase in resistant infections. And we've not recovered from this. MRSA is higher than it's ever been. We've, both in Philadelphia and here now in South Carolina, I've been here for almost a year, have been looking at our antibiotic prescribing over the last couple of years, and antibiotics have been prescribed at higher rates over the last couple of years. There are a lot of theories out there about that. The honest answer is we don't know why, but the things that are being floated when you're providing, bless you, those who are being provided care virtually we may be, because we're not doing a physical exam and because we're not actually seeing the patient, maybe we're practicing more conservatively and we're more quick to prescribe antibiotics. We're not as judicious with the antibiotics because we are just trying to manage and mitigate risk when we're not actually seeing the patients. That's one of the things being contemplated. And there are some studies that are going on right now about antibiotic prescribing patterns in telehealth versus in-person health. So, but this is a challenge, and there's no quick way to solve for this problem. So, there's been a pretty significant decline in patient safety, both from a population perspective, from a hospital and acute care perspective, and even from a biologic perspective with regard to, resistant increases in resistant organisms that all of you are seeing, in your clinics and in your patient populations. So, it's really amazing to see, this significant shift. And when I say significant shift, I mean, 2 years ago, sepsis ODE mortality across the country was at a 1.0 observed to expected ratio, right? Right now, on this day, nationally, sepsis ODE mortality is 1.21. So there has been a significant decline in safety. It's been across the board. There have been very few that have been able to buck that trend. And really, we have people starting to scramble around this issue, but not knowing what to do. So CMS doesn't know exactly what to do. They, paused their hospital rating programs, and they've extended, we're still looking at data that's pre-pandemic in the hospital rating programs from CMS because of the tremendous variation and impact on outcomes to hospitals from the pandemic. And the current performance during the pandemic and even up to now, which is still impacted, will impact rating programs and value-based purchasing programs through 2025. And so, there's been a pause on a lot of those value-based care initiatives and ranking programs. So, a lot of challenges now around internal and external benchmarking to know how you're doing relative to the country. The leapfrog scores for the fall are going to come out in a couple of weeks. It's going to be a very sad story, I predict, the New York Times, because of the Delta and Omicron waves. So the new fall reporting for leapfrog is going to include the Delta wave. The Delta wave was brutal and won't include the Omicron wave because it goes through the end of December, and really the Omicron was just getting started. It's going to be pretty dramatic, I think, impact on the leapfrog scores. It's causing all kinds of challenges for goal setting with hospitals to know how you're doing. Boards are confused and don't know how to respond to their own performance. And it'll have a significant impact on value-based contracts and their performance. So, so that's from a sort of industry and almost a payer perspective. But, for us in healthcare clinicians, we should know exactly what to do, which is we need to, all of the hospital-acquired infection indicators, we know the things that we can do to mitigate those risks, and we need to fully commit ourselves to taking action. And I think that action needs to be even more deliberate and focused now because we have so many new individuals in our care settings. For our organization here, we this year, coming out of those new nursing graduates, we have 631 new nursing graduates in our organization this year. That is a huge number of brand new nurses, right? So the approaches to patient safety, need to account for that, right? We need to come alongside those new team members and help them. So, I think the challenges are really profound, in all of the evidence-based practices that we have around infection prevention, infection control, hospital, all forms of hospital harm. We need to double down on those approaches. And then, when we think about the approach to safety, what is being called for by the IHI, and CMS is soon to endorse this as well, is the need for a total systems approach to safety. And I'm going to walk you all through what that looks like and what I'm even talking about over the next couple of slides. But I do want to reference one of my heroes in this moment, which is this is Florence Nightingale. If you don't know, Florence Nightingale was fierce and she was awesome. She was a nurse during the Crimean War. She did things like reduce hospital mortality by 50%. Action items included, let's get the horses out of the hospital. Just a very, focused, deliberate approach to improving outcomes. She's credited with inventing the pie chart, which is an amazing thing for your CV. And so, I do think that some of the lessons from the Crimean War really impacted safety. And I do think that, what's one of the things that's going to come out of the COVID-19 pandemic is a real call for an adjustment to how we approach safety and quality from health systems. So I'm going to go a little bit through that over the next couple of slides. And as before I give you sort of the vision where I think total systems approach to safety, how that looks, I want to just reference a little bit about how we do improvement in healthcare. So, and I put this in there for you, Dr. Richter. This is a study that we published around overactive bladder systematic review from the SGS systematic review group. But on the top left, what I'm demonstrating is that a traditional approach to quality improvement in healthcare has been when there is clear evidence, we convene the experts and they contemplate what our practice in our, say, health system or department should be around the management of said condition. We evaluate the evidence, and over some period of time, we establish what that standard of care should be. And then we disseminate that knowledge to our colleagues. So in this case, We disseminate, the evidence around non-antimuscarinic treatment for overactive bladder. We establish our treatment, paradigm. We communicate that out to people, and then maybe we track the outcomes. And that's our approach to improvement. And really at scale, at large scale. So for example, in our health system here, we have 3,200 members of our medical group across a large geographic area. And it's just too difficult to communicate and to get everyone on the same page. So that approach, while it is rational, does not have system-wide impacts. And so, there is a need for a different approach rather than just establishing a guideline and then disseminating it. So I'll get to the solutions in just a minute. But the top right is process improvement is one of the methodologies that's often used in healthcare, which is incredibly important, but is also insufficient because we design better processes, but not better tools. Oftentimes we don't get the results that we want. And on the bottom right-hand side, I've got BPA. So I think everyone here is aware of best practice alerts, and that's putting actionable insights into the workflows of caregivers. And that's an approach that has produced some significant results in healthcare. But they're really these are kind of one-off efforts, and there really isn't a total systems approach that health systems have used over the years. And that's really what the need is for trying to pull together the various improvement methodologies in one total systems approach and make it more clear how we learn and improve at scale. The other thing that I mentioned earlier is the focus on culture as an improvement methodology. So I gave this one a slide of its own. Essentially what we know is that safety culture is incredibly important in managing safety in an organization, but it is also insufficient. So this is a systematic review of trials that are looking at the intervention of a safety culture at health companies. And what you see is there is not strong evidence that safety culture interventions have an actual scaled impact on harm reduction. Obviously, there are certain instances, someone felt comfortable and they spoke up and the patient didn't get hurt. So there are a lot of great stories that are out there, no question about that at all. It's just, is it a significant impact at scale? And does that intervention at scale, think intention to treat, does that intervention at scale actually produce a reduction in safety events and harm across hospitals? And the evidence suggests that it really doesn't. So one of the things that I talk about a lot is that having a culture of safety is incredibly important and also insufficient. We have to also have dynamic learning and improvement safety management systems, which are incredibly important and also insufficient. If you have the systems, but you don't have the culture, or if you have the culture and you don't have the systems for improvement, you have to have both. So what I'm going to do is I'm going to show you a little bit about what I think CMS and others are going to be calling for and some of the work that we've done here around building a total systems approach to safety. And as we go through this, as IHI and CMS and others are calling for a new and different approach to safety, a total systems approach to safety, we're doing that at a time where our folks are exhausted. Try harder and do better never really worked that well in healthcare. It's definitely not working now because people are so fatigued, and we have people leaving the workforce in droves. In the last 12 months in the US, we've had 117,000 physicians leave the workforce, and many due to retirement. And I think what's most concerning is physicians in their 40s and 50s that are leaving care delivery for other roles outside of healthcare. The story in nursing turnover rates around the country are approaching 25% in some areas. So, what we have is a patient safety crisis, and we've got a workforce that is strained, and asking them to do more or do differently is, I think, going to be that's a tall hill to climb. So, these are a difficult set of circumstances. So, here's how I think this goes. Organizing thoughts. Number one is that excellence is really built. You can't teach and share your way to excellence. Quality and safety is not something that you can culture your way towards. You really have to build a total system around how you manage quality and safety to enable a culture of excellence in the organization. So that's one just organizing fundamental thought around how you build quality and safety systems at scale. One is it really is about building great systems that enable a great culture. And then the other thing is building a highly visible elite safety and quality management system that serves people. So, and I'm going to walk you through a little bit about what these systems look like and what our system looks like. And then we'll give you all an opportunity to ask some questions. So all that is sort of preamble into what, I think some of the lessons were from COVID-19 and where the industry is going to be shifting its focus towards a total systems approach to safety and even towards a higher level view of safety at a population health level. So what I'm showing you here is the safety management system at our organization, how we manage safety. Our safety system is actually branded Pulse. And it's a dynamic learning system that enables all team members to participate in our daily activities to identify and mitigate risks, to improve our safety, and to support people that have been involved in safety events. Our learning and improvement system enables our culture of safety. And these are 6 of the main components of that system. On the top left, you've got our Pulse Power system, which is a learning system. This is on every desktop, on every iPhone, everybody in the organization, where you see an issue, a risk, a harm, a hassle, a hazard, you can report that into us, and we will escalate that up in a very structured, rapid way to be resolved and mitigated that day. Clear expectations around that. We have performance improvement boards in every unit across all of our hospitals and in our ambulatory settings that are called an A3 format, which is where they're identifying the risks and threats, and they have a very simple basic process improvement and project management tool there on their units to help them work through their issues that day. We have an escalating tiered huddle process. This sort of design was made famous by Intermountain Healthcare with one of their publications in 2018. The idea for this, and I don't know, maybe if you all could tell me if UAB does this, I just don't know. But this is where you have very, very structured huddles that begin at a unit level, every nursing unit, every ambulatory location, and every post-acute and non-hospital based or ambulatory based setting, that all those huddles occur at the exact same time in a structured way where the data is being collected. Unmitigated risks and threats are being escalated up to the hospital level, or in the ambulatory side to the market level, and then up to the enterprise level. So for example, in our organization, I sit on top of the enterprise daily huddle every morning at 10:45. It lasts 5 minutes. If it lasts 6, I start to lose my mind. And we are identifying the unmitigated risks and threats to the organization, triaging those, and tracking them to resolution on a real-time basis. So this is a best practice. There are a number of health systems around the country that are doing this, and it's about being very, very highly capable of identifying the biggest risks in the organization, escalating them, and having them resolved today. So as an example, today I identified that there is an order set problem with our TPN that could potentially result in harm, and that was identified at a unit level and has already been resolved today. So on the top right, how we respond to serious safety events and how we do RCAs is really important, and I'll walk through that in a little bit in just a minute. And then how we support our team members and our patients when they've been involved in safety. So this is a total systems approach to safety. It's how we learn and improve every single day, and this is sort of the beating heart of the health system, and is separate and apart from the proactive management of safety in things like hospital-acquired infections, falls with injury, and pressure ulcers, all the things that we know that we manage on a proactive basis. This is about identifying, today's risks today. So the number one source of harm in healthcare today is medication errors. 5% of patients that come into a hospital receive a medication error that results in harm. All of that harm is occurring in plain view of an electronic health record. And in my view, the EHRs are facilitating harm. And so, and taking a total systems approach is the opportunity to redesign those systems to make them more of an active participant in the mitigation of risk rather than a passive participant in harm. Make sense? So, so that's really what we're trying to get to in this type of the system, is those systems issues that lead to common harms, with the goal of developing a clinical operating system that's a great supporter for people, right? That facilitates people doing the great care that they want to provide every single day, and engaging them in that process. So I mentioned how we respond to serious safety events as a core component of a total learning system and a safety management system. So this is the study, and I put this in here just to prove, Dr. Richter, to you that I'm still publishing this. This was published this year in the Journal of Patient Safety, and it is a study that we did after integrating human factors engineers systematically into the root cause analysis process across a health system. And human factors engineers are a unique talent and gift and discipline. And I'll get more into that in just a moment. But the point of this is that in healthcare, we've really taken a amateur approach to safety. We haven't really reached outside of our industry into engineering, which is how other industries became very, very safe. So the way that and I'll use the tired airline analogy, which is imperfect, but the airline industry didn't get to very few safety events by having a great culture of safety among their pilots, or by training their pilots. They got to where they are with safety by building their great pilots better airplanes. And at this point, because healthcare is socio-technical work, because healthcare is really a complex human-machine interaction, there is now the opportunity to apply the science of human factors engineering to the total systems design for healthcare. So, and I'm going to get a little bit more into that in just a minute, but a couple thoughts. One is that healthcare is socio-technical work. The machines are no longer our tools, they are our partners in the delivery of care. And we are just at the beginning of that. As I said, when To Err Is Human came out, less than 10% of hospitals have an electronic health record. Today, almost all of them do. All of these tools that we're interacting with on a daily basis are producing massive amounts of data that we're not using proactively to help us to mitigate risk. I mean, there's some examples, but very few. So, the digitization of healthcare is recent, and we've not yet leveraged it in safety in meaningful ways from my perspective. A third of the new data in the world this year that's created is going to come out of healthcare. There's a white paper that came out of McKinsey that said as much, and that makes a lot of sense. You all are sitting there at UAB Hospital, great, amazing hospital, I think 1,100 beds, and every click lives forever. Every heartbeat that's recorded, every data point lives forever, right? We're producing massive amounts of data, and there's a real need to use that data proactively to serve our patients to make our care more safe. And the modern patient safety movement, To Err Is Human, really predated the massive digitization of healthcare, which is why it was largely focused on social systems approaches like culture as an improvement methodology. And the modern patient safety movement really hasn't caught up and really hasn't, taken system safety science approach to safety, because as an industry, it's just not something that we've done. So I'm going to go back to a little bit of storytelling, which is this is the story of the B-17 bomber. The B-17 bomber played a significant role in the Second World War, and there was a problem with the B-17 bomber, which you will easily identify, that it was landing on its belly. And the reason for that is that as the pilots were landing the plane, they felt down. There were two levers. They looked identical. They felt identical, literally identical. I've sat in a cockpit, and one of them controlled the wheels and one of them controlled the flaps. And it was very easy for them to mistakenly raise the wheels while they were landing the plane. And so it was a design issue, right? They did all the things that we do to try to mitigate this risk. What's wrong with our pilots? We need to put a committee together. We need to do a root cause analysis. We need to change our onboarding. We need to put a Post-it note on the dashboard. We need to hold people accountable all those things, and had almost no impact on this outcome because it was a design issue. It was not a culture issue. It was a design issue. And the way they ultimately mitigated this risk is they put a rubber band on the lever that controlled the wheels. So when the pilots were landing the plane, they felt rubber, they knew that that was the wheels. And so this error rate went almost to zero. So, in healthcare, we're still focused on the pilots. We're really not putting rubber bands around the gears the way that we should be. And so that's what I'm talking about with human factors engineering. And if you look at this, there are a lot of examples of systems in healthcare like that airplane cockpit that are facilitating harm. This on the left is a safety event that I was asked to weigh in on, where there was a wrong-sided chest tube placement in a baby in a NICU. And the image on the left is what is presented to the care team as they're trying to determine the laterality of the patient. To put the chest tube in, it is incredibly confusing and exceeds human capabilities during a crisis like that. The green one is the one that actually represents the orientation. So this is a system that exceeds human capabilities during that time. And so that's no longer on the market. The one on the right is there was a defibrillator recall that occurred a couple of years ago. You all may remember, huge issue in healthcare, and where the defibrillators would fail if you unplug them from the wall, and they would just turn off, which is a problem if you're pacing a patient. And so there was a need to remind people to keep it plugged in during treatment. And in many health systems, what they did, and there's evidence around this now, is they sent emails out to their team to remind them, right, that you need to keep it plugged in. How much impact do you think that had? Right? Because you're using this when someone is literally dying in front of you, right? And so it doesn't work. So here's a human factors approach, which you put the information inside of the workflow, right? This is telling you inside of the workflow how to mitigate that risk. And so there's just a need in healthcare to change our thinking and not to just be focused on disseminating information, putting action inside a workflow. This is an example of alarm fatigue. I don't think the audio will work, so I won't try it. But if you turn on the audio here, you can hear a cacophony of noises that are totally uninterpretable. There's no human that could possibly. Oh, there it is. Can you hear it? Okay. Well, if you could hear it, essentially, it is very clearly a system that exceeds human capabilities and doesn't account for human limitations. So through incorporating human factors engineers into how we perform root cause analysis, we really move from weak action items to strong action items. Weak action items are things like we're going to change our education and training. We're going to develop new rules and policies. We're going to develop a new checklist, and that's how we're going to mitigate the risk. Strong action items are things like we're going to remove the risk from the environment. So I'll give you an example. I was asked to work on an RCA around MRI safe ventilators. These are ventilators that are allowed to be in MRI rooms. That can only be so close to the MRI. If they get a little bit closer to the MRI, then they get pulled in, which could of course kill a patient. In this situation, an MRI safe ventilator did get pulled into the magnet. Thankfully, no patient was harmed. But the way that they had mitigated the risk is they had a piece of tape on the floor in the MRI room to remind people that the ventilator can't go across the line. Of course, that system failed, right? Predictably. And so, a weak action item in that, and you can imagine this happening, right? Would be, hey, what's wrong with our people? We need to change our training. We need to hold people accountable. We need to put a post-it on the door. We need a new rule and a new policy and new checklists and another timeout, right? When a human factors engineer does that and say, hey, folks, why does the MRI safe ventilator have wheels? Number one. Number two, why is it not bolted to the wall, right? It should be impossible. We should remove the risk, not just mitigate it. We should remove the risk. And this is just the thinking that healthcare really hasn't. So why has healthcare really not done this? It's because we don't really understand human factors engineering expertise. There might be a dozen human factors engineering teams in healthcare in the whole country. The leading team is at Georgetown MedStar. And so we don't understand it. So therefore we don't have it. And therefore we don't know really how to use it. And companies supplying technology to healthcare don't have clinically informed human factors engineers expertise. Evidently, the FDA process for human factors engineering evaluation of technology coming into health system is inadequate. I will give you an example of that. There's a defibrillator that is on the market today, where the on button is the off button. In order to turn it on, you press and hold. In order to turn it off, you just quickly press it. Make yourself a pediatric nurse and you go and you grab a defibrillator for a patient that's coding, and you grab it off the wall and you put it down on the bed and you press it, and what happens? Nothing. And you're pressing it, pressing and pressing it. Eventually you hold it long enough and it turns on, but you don't know why, and you're still pressing and you turn it off. So you don't know why it turned on, you don't know why it turned off. And you know, that's a system that exceeds human capabilities and limitations. So obviously the manufacturer that designed that, they weren't accounting for human limitations. They weren't accounting for the actual work is performed, what a code looks like in a trauma bay, and the scenario of that pediatric nurse, that maybe yes, she's been trained on the tool, but she's been trained on 100 tools. And yes, she knows how to use it, but she hasn't used it because she's a pediatric nurse and they rarely do codes. So it's a system that is designed for a world that doesn't exist, right? And so there's just insufficient integration of human factors engineering with design of healthcare. And really, human factors engineering expertise is basically unavailable. There might be 30 clinically informed human factors engineers in the whole country. So what all this looks like when you do recruit a human factors engineer, if you're lucky enough and you incorporate them into the review of serious safety events, and you ask them to help you land their planes on their wheels, is you get to a place where you are rating strength of action items coming out of all serious safety events. And you can actually apply probability to the recurrence of an event based on the strength of action items as determined by engineers for the recurrence of a safety event or the causal event that led to the harm. And so, you know, this is the methodology that we published and developed around the characterization of action items coming out of serious safety event reviews. And again, this is all about how strong your action items are and how likely you are to remove the risk from the environment. So I can you know, pause there maybe and just say that with regard to serious safety events, people ask me this all the time because I work in patient safety and do a lot in that space, in this space. You know, John, if there's one thing you could know about a hospital, say you're having a stroke in some, you know, city in America, and they told you could know one thing about a hospital to determine which hospital to take you to with regard to safety. And I tell them, you know, if I could know one thing, it would be how they respond when somebody gets hurt. It tells me a lot. I want to know that more than I want to know your leapfrog scores or your US News and World Report, is how do you respond when somebody gets hurt? Who shows up? How long does it take? How quickly do you implement stopgap measures? How strong are those stopgap measures? How strong is your action item? How quickly are those action items implemented? And you know, how do you take care of the patient and the caregiver who were involved in that serious safety event? I say that how an organization responds when somebody gets hurt is a defining characteristic of that organization, and you can't be any better than you are in that moment. So I'm going to go a little bit through just a couple of more aspects of the safety system. Dr. Rich, I think we've got time, right?
We're kind of nearing the end, but we started a few minutes late. Maybe you could start winding up, John.
Yeah, sounds good. So I think I'll pull up there and say that you know, I do think that we're at an important moment right now in patient safety. I think that there is going to be significant attention paid to safety over the next couple of months. When the leapfrog scores that come out, the president is going to make statements about this. CMS is implementing new guidance, and the Joint Commission is going to be they're doubling down on new approaches. And so, you know, I would look for that. And if we're as an industry smart, what we're going to do is we're going to adopt a total systems approach that does incorporate the science of human factors engineering, you know, into you know, the management of safety on a daily basis. So maybe I'll just wrap up there.
All righty. Any questions? John would be very happy to answer any questions.
Do you all have a rapidly escalating tiered huddle system? Does it that your C-suite's involved with every day? Do you know?
I know we have huddles that go on various floors and over in the clinics and both ambulatory and inpatient. I'm not sure they're as regimented as you define, where everybody does it at the same time and that, but I know that is done and done on a daily basis. I'll tell you, this is a lot of information, and you describe a population based approach to safety. You describe kind of a medical system approach to safety, but to my mind, we all know too that both medical organizations and infrastructure, as well as the government, i.e. CMS, they're also very concerned about fiscal issues associated with implementing all these types of programs and that. I mean, we all know it's the right thing to do, but have you actually provided, or have you actually generated cost effectiveness data that would, kind of bear out the point of why this should be done and why it's a particular approach is the way to do this?
Yeah, so we have a paper that's coming out right now around sepsis work that we did using human factors engineers to design systems to manage sepsis, which is a really complex workflow, as you know. And the 12-month savings on that work for the organization was 26 million.
Yeah, that's compelling.
So that's pretty compelling. And this is now my third sort of health system that I've done the same work around sepsis, and all that work went live over the last couple of months. And just last month, the first month, the net impact was 1 million, okay, in 2 of our 18 hospitals. So when we scale it up, we'll get to somewhere between 3 to 4 million a month. And we're talking about saving lives and reducing costs.
Yeah.
So, but I would say that there are, you have to take them one at a time, right? In terms of the ROI, there'll be some things that we do that there's not going to be an ROI. It's a moral issue. Take, for example, the MRI.
The right thing to do. Exactly.
Yeah, take the MRI safe ventilator, right? There may or may not be a business plan for bolting that thing to the wall, but sure is the right thing to do if it's your kid, right? And so I think there are a lot of different answers to that. There is, I think there's a real need to have physicians, managing safety and partnering with finance, like we did on the sepsis work, right, to sort of develop that ROI and the business plan go forward. But existential threat to healthcare today, no question, is that we have an expense crisis. And it is serious, and it is impacting hospitals in the most vulnerable communities more significantly than everyone else. And I think it is telling that we have, as a country, done loan forgivenesses for businesses, but not for hospitals. And it's a real mistake. And so I think if there's a regulatory response to this, it's expensive around the patient safety crisis this time around, but there's not funding that comes along with it, I would predict, a lot of upheaval.
Good deal. Thank you. Are there any other questions for John? Well, I learned a lot, John. Your efforts in this area are obviously being noticed, and continue the good fight, and hopefully we'll talk soon.
Yeah, sounds good. All right, you all have a good weekend.
You
Thanks
too.
again. All right,
Roll Tide, John.
Go Dogs. What are you talking about? Yeah.